Hello, I'm Dr. Lisa Straight. I'm an associate editor at Gastrointestinal Endoscopy. It's my pleasure to be here today with Dr. David Tate, who on behalf of his co-authors will discuss an article entitled Endoscopic Submucosal Dissection for Early Gastric Cancer, Absolute versus Expanded Criteria in a Large Western Cohort.
Thank you for inviting me.
It's a pleasure. I work in a safety net hospital where we have a lot of Asian immigrants, and we're increasingly aware of precursors of gastric cancer and early gastric cancers, so I really read with interest your article.
I think that's a really important point, and actually in this article we have really tried to address exactly that point. So this is a prospective analysis of 135 either early gastric cancers or precursor lesions for early gastric cancer, and the clinical features, also the histopathological features over a long time period.
Yeah, it's really a great work, a large amount of work that went into it. I thought just for people who are listening, if you could talk a little bit about the absolute versus expanded criteria and a little bit about how your study differs from studies that came before it.
So that's really important. I think that our study is the first prospective Western study in this area. Certainly previous studies, particularly most of the Eastern literature, has been retrospective and has included histopathology at the outset to define these lesions in a stomach. In our situation, we have taken the endoscopic appearance of the lesion, its size, whether it had ulceration. We've described that, and we've matched the outcomes to that situation, and then we've matched the outcomes with the addition of histopathology in the traditional Japanese absolute and expanded criteria to give people an idea of the answer to the question, well, I have this patient with a lesion in their stomach. It's of this size and it does or doesn't have ulceration. What should I do? What will the outcomes be? Because of course we know that histology is not, although it's important to take biopsies, the biopsies are not predictive of the final histology once you've resected that lesion.
And what were your major findings?
So our major findings were, firstly, that endoscopic submucosal dissection in a Western center, in this case Sydney, is safe and effective. And to refer to this, in this study, the R0 resection rates were high, and the en bloc resection rate of 94.8%, R0 resection rate of 86.7%, but then a curative resection that's slightly down of 79.2%. And this is actually less than the large Eastern studies, but very much in line with the other very large Western experience that's published in the literature.
That's very interesting. And I know in your study you talk about maybe that your experience may not be as comparable to the studies, for example, in Japan because of a learning curve. And I know this is a relatively new technique in Western countries. If you could talk a little bit about the learning curve in terms not only of performing the ESD, but in recognizing these lesions.
Then that's so important. Of course, as you know, as you're aware, I'm sure in the United States, that there's a very limited ability to train in the technique of endoscopic submucosal dissection, particularly in the stomach, because there is a perception that these lesions are not common in the West. Now, whether that's true or whether it's an issue of detection, I know that you could discuss that, but certainly a lot of people having to travel to an Eastern center to get experience in these techniques. As people become more experienced, I think that will change. And certainly in our center, for example, in this study, there were 3 endoscopists. The initial endoscopist learnt in a Japanese center from observation and from practical experience, and then taught the other 2. And those 2 there was very little difference between the endoscopists in the study. So it's certainly possible to learn this technique in a Western center from someone who's experienced and performing the technique.
But in your paper, I think you made reference to 12 months of study, so that's a pretty intensive amount.
It's an intensive commitment for your life if you're going to go and travel to an Eastern center for that. And so we have to develop, as colleagues in the West, training pathways for our trainees in this technique.
Other than the technical aspects perhaps being different, or the learning curve or the experience, do you think there's a difference in the biology in the cancers that might impact the ability of ESD to curative resect these early cancers?
I'm not sure about that. I have to say probably not, but there are certainly differences in the types of population that we are seeing, for example, in Australia versus what they might be seeing in a Japanese center, for example, or a Chinese center. I think the risk factors are mainly environmental, to be honest, and probably those populations take those risk factors with them in their communities in other areas. So no, I don't think there's a biological difference.
Okay.
Although our study provides no support for that theory.
I thought it was interesting that the lateral margin is such an important thing and so difficult to demarcate. Do you have any advice about both finding these lesions in the stomach and then trying to demarcate the lateral margin? What techniques do you use other
It's
than
very,
careful
very,
inspection?
very important. I think the first thing to do is spend time. So we talked about this, but in Japanese centers, they're spending at least 20 minutes doing an upper gastrointestinal endoscopy. I know that in our centers, we are not doing that. Also take lots of photographs so that if there is an at-risk patient, potentially with intestinal metaplasia or an atrophic stomach, that later on you can refer back to those images. If you find a lesion, potentially you look back 2 years ago or however long it was, you screen it and check that. But if you identify within a diseased stomach no demarcated area, then there's a certain protocol for biopsy that we would follow. However, if you identify a demarcated area, then it's very important to biopsy that area. And of course, if that area is dysplastic, then that area should be resected with a technique that can achieve en-bloc excision in the stomach, and really the only technique that's proven in that way for lesions over 10 millimeters, which is most of them, is endoscopic submucosal dissection. And of course, because we know that forceps biopsy is an unreliable predictor of final histology. So all those areas, if they're dysplastic, should be, obviously you talk to the patient, you consent them, but attempted for endoscopic resection.
And unlike maybe biopsies of the colon, it's okay for a clinician who might refer to an expert center to biopsy these lesions?
I think that's important. I think we're not at the stage where endoscopic imaging, and that's actually a very interesting point. In this paper, we explored the role of endoscopic imaging, and even in Japan, it doesn't seem to be possible to accurately predict histology in the way that you can in the colon. For example, you see a depressed area in the colon, you think maybe there's a submucosal invasive area. That is not the same in the stomach. The presence of ulceration maybe even precludes resection. So we just don't know. And endoscopic imaging is good for delineating the lesion, but is not very good in our experience for detecting the degree or the extent of the dysplasia or cancer. So it's important to biopsy all these lesions.
And how important is expertise in pathology? We're talking about expertise in endoscopy, but you have partners in this, which are your pathologists.
So we've got two fantastic pathology colleagues in Sydney who reviewed all these specimens, and it's really important. And it's not just important to read the pathology report, but we had monthly meetings where we sat down, we looked at the histopathology slides, and they looked at the endoscopic images. And you really can learn from each other. You can learn from each other. They're learning about how good endoscopic imaging these days is in demarcating these lesions, and we're learning what it looks like, and often the outcomes were changed from discussion.
And what do you think future directions are? You've sort of proven it's feasible, it's effective in Western populations. You've raised a lot of questions about this technique and about detecting these patients and these lesions. What do you think are the next steps in this field?
I think there's two important things. The first thing is the training for our younger colleagues in these techniques. We need to be providing pathways and structured curricula for training people in endoscopic submucosal dissection, particularly in the stomach. And the second thing is that in this study, there are about 20 outside criteria resections, and of those, I think 11 or 12 patients declined surgery. They said, I'm not going to go forward. Either they're too frail or that was their wish. And in those patients, we only saw, to a median follow-up of, I think, 8 to 10 months, one recurrence. So actually, that does suggest that endoscopic submucosal dissection in the stomach is a good local disease control for patients who can't, for example, undergo surgery or chemotherapy for other reasons. I think that's an important point for the future and an important research going forward.
Thank you very much for discussing your interesting article and moving this technique into the Western population.
Thank you for having me.